Hi, my name is Jared Lettery, and welcome to the AI Academy. Our next speaker is Dr. Assaf Ben-Meir. Assaf's going to talk about interpreting literature. One of the things we've all experienced is an absolute increase in the number of publications on AI in assisted reproductive technologies. For example, 34 abstracts in 2021 at ESHRE. This past year, there were 55. I think that was on last count. And Assaf's going to talk about how to interpret literature so that we can make intelligent and informed decisions about the tools up ahead.
So thank you for joining me in this AI Academy session on critical reading of studies using AI. My name is Assaf Ben-Meir, and I'm the director of IVF unit in Hadassah Medical Center in Jerusalem. The session I'm about to present is the result of the last 8 years research that I led, and which contribute to a startup named Fairtility, a startup that I serve as the chief medical officer and co-founder. And this is the only conflict of interest that I can talk about. Right now, you had the chance to listen to my colleagues in the AI Academy who shared with you in details what AI is all about and how it can be applied in medicine. As AI is a new method used in research, we need to understand the strengths but also the pitfalls of using AI in resolving problems. In this session, I will highlight what we need to pay attention to when reading an article using AI technology. Before we start, let me do a quick recap about basic terminology in artificial intelligence to bring everyone to a common denominator. During the 60s, artificial intelligence was introduced as an automated system that can perform tasks that we consider to require intelligence. Later, machine learning was developed with the ability to learn from and make prediction using data. Deep learning is a subgroup of machine learning that use several layers of function to be able to predict the results. Usually, the task will be to differentiate between two groups. In our case, it will be to differentiate between high and low potential embryo implantation. Today, most of the AI algorithms are based on deep learning by neural networks. The neural network is based on neurons' activity. In biology, the neuron gets several inputs and sum them, and if it is above a threshold, it will deliver an output. The same artificial neurons gets input from several parameters, each one of them with its weight. A neural network has several layers, and in each layer, different function can investigate the output of the previous layer. The output is checked for its error, and then formulas in the layers can be changed, and the error is examined again to find if it's getting better or worse. This is called error backpropagation. As a result, machine learning models differ from decision rules because the accuracy of the machine learning model can be improved over time. Eventually, the system will get the best result for the data, and it will be generalized, and hopefully in such a way that it will explore correctly new data. Such method of AI can examine big data or analyze pictures or movies and predict outcome that we define. The data should be tagged first as normal or abnormal cases. That is called annotation. Then it is being split into 3 different parts. 60 to 80% of the data will be the training data that the algorithm is trained on. The second part is to validate and fine-tune the algorithm. Lastly, for test and deployment, it is critical that the machine is not exposed to the test data, which is the final event to examine the accuracy of the system. The main strength of AI is deriving from its ability to analyze automatically, objectively, huge data without getting exhausted. something that we humans are unable to do. So what are the pitfalls in building such an algorithm? The heart of the algorithm is not the mathematical features or which AI artificial neural network we use, but the dataset. It's all about the dataset. Let's discuss this in more details. The data size should be big enough and tagging should be correct. In some of the cases, there is disagreement between experts what is the correct tagging for the sample. In other cases, you can find that there are several definitions of normal and abnormal. Let's take the case of abnormal embryo tagging known as negative implantation embryos. Is it an unimplanted embryo, but then it might be because of the abnormal uterine cavity? Or is it aneuploid embryo by PGTA? Another obstacle in arranging the database is missing or false data. We all know that database is never perfect, especially if it was collected retrospectively. Also, we need to scan the database to see if there is false results, like the progesterone level is in millions, or the patient was pregnant hundreds of times. Leaking data, it means that machine analyze the outcomes with parameters that have nothing to do with the task. Sometimes it is difficult to find leaking data because the algorithm is a black box. You don't really know at first glance what it is looking at. Let's take a look on some examples. In this case, we asked the computer to differentiate between dogs and wolves, and it did it correctly. But when we used another data set, it was all random. Investigation into what the computer was looking on, we found out that it did not recognize the animal, but rather the environment surrounding the animal. If there was a wide forest or snow, it will tag it as a wolf. And if it recognizes any domestic features like floor and seats, it will tag it as a dog. Of course, in another database or another data set, those rules will not necessarily apply. Another example is a study from one of the hospitals tried to train the computer to differentiate between critical and non-critical patients in the emergency room by chest x-rays. Again, the computer did a good job on the training database, but when the investigator tried to run x-rays from another hospital, they found a random decision. They found that in their hospital x-rays, there will be an upward arrow on the film if the patient was standing, and horizontal arrow if he was laying down, which is the cases in most of the critical patients. The computer was looking for the arrow and in fact was not looking at the chest x-ray to make its decision. Of course, the issue repeated itself on film from other hospitals that did not put this arrow, and then the result was random. To overrule this pitfall, we should train the system on a very diverse dataset from different clinics, and the first step of analyzing those pictures will be to segregate the interested area of the picture. Overfitting is a scenario in which a machine learning model memorizes the training data too well. The result that the model does not recognize or generalize the new data sets. We usually find overfitting when there is small data set, which is sometimes the case in medical research. As mentioned before, using neural network means it is a black box. We will not know what the reasoning for the decision. This is a new area of research on explaining the machine decision. Algorithm that will be able to provide an explanation answer the why the model reached its outcome. and it will be more transparent. This will lead to gaining trust and acceptance by the medical staff. Finally, we should always remember that we deal with retrospective dataset, so we can find association and not necessarily causation. During the last 10 years, there is an exponential growing in number of studies on AI in reproductive medicine. You can enter reproai.org and you will get an update list of all papers. You can see that in 2013, there were just a few papers on this topic, and since then, the growth is exponential. If we want to investigate the growing amount of studies, we need to carefully assess the following aspects. First, we need to make sure that the research outcome applies for the general population. For example, some of the studies presented here describe AI-based algorithm trained using data from a single clinic or with very specific inclusion criteria. Another aspect to carefully look at is whether the dataset is balanced. An AI algorithm is trained to find the best performance with the specific data presented to it. When the training set is highly unbalanced, the model may be prone to intrinsic bias. Let's take a look at one of the major studies in the field published by Train and Gardner on prediction tool for embryo potential by investigating videos of blastocyst development from time-lapse incubators. As you can see, the database seems to be very impressive, large and diverse from 8 different clinics. The result introduced by ROC analysis with AUC of 0.93 looks really good. And then we look at the data set and find that negative samples included discarded non-viable embryos. If we compare this to our daily work process, such embryo will not be part of the embryologist's decision which one to transfer, as they are deemed non-viable. If we look even further and deeper into the dataset, we found out that of almost 9,000 embryos that are included, just 694 were positive implanted embryos, which is 8%, and the rest were negative. Also, most of the negative embryo were discarded embryos. This is an unbalanced dataset with 80% of the cases that are not really relevant to the question that the embryologists have to answer on day 5. If the algorithm learned just to differentiate between discarded embryo and viable embryos, and from the viable embryos, it will do almost a random decision of which is positive and which is negative, you will get the same result of an AUC of 0.93. But if you remove the discarded embryo from the dataset, we see that the AUC reduced to 0.55, which means that it is not a fine prediction tool. Let's consider additional points when reading studies on artificial intelligence in IVF. Obviously and naturally, AI algorithm should be trained on large databases because a small sample size can compromise the model's performance and introduce overfitting. Algorithms for AI in assisted reproduction are usually classification systems that predict whether a biological sample has a good or poor prognosis. This classifier can be assessed using different metrics. Accuracy and area under the curve are the most common. However, with these metrics alone, the reader cannot evaluate a deeper performance analysis. For example, if the model is more prone to error in one class or the other. A good practice in this area is to be fully transparent by reporting the confusion metrics or presenting a table with the testing case, prediction, and true results. In such way, we will be able to calculate the performance by ourselves. In summary, Biggest strengths of machine learning model is consistency and the lack of fatigue. Critical reading of AI studies should include size and distribution of the dataset. How was it annotated? Is there overfitting? Is there transparency for the AI results? Thanks again for joining me on this session in AI Academy, and I hope those points will help you during reading the next study using artificial intelligence. Thank you.
Assaf, that was excellent. I really like the way you incorporated in that trans study and took that apart and really got down to the core issue of what the true AU was. I'm having a little bit of feedback. I did have a couple of questions. You may recall probably 3 or 4 months ago, ASRM had a forum involving several different people that was moderated by a reproductive endocrinologist. And the meeting really started focusing in on the role of randomized controlled trials as being an absolute necessity before adopting any of this technology. I'm wondering if you could comment about how you would see literature playing out. For example, with antibiotics, RCTs are simple, very straightforward, and you get fairly solid conclusions about whether or not you should use an antibiotic. But we're in a different field now, and I'd like your impressions about how we can safely move this technology forward and what kind of literature we can use to support those decisions.
Okay, so I think AI is totally different from a new medication that we get into the field or new imaging. AI is mainly based on data. And in this case, data can also be retrospective. So it is not really necessary that all the studies should be prospective randomized controlled trials. The technology of AI is much faster than any prospective randomized control trial that we can do. And for this reason, if we will wait until we have a randomized control trial, we will have to postpone any AI technology for another 5 to 10 years. And this is not, I don't think it's a doable. And again, we can get a real nice, and we can prove the efficacy of AI technology without a randomized control trial, as if we will be able to use a really big data, even if it's a retrospective data, and to prove that the AI technology is really work.
Yeah, that's excellent. That's very well put. I would agree with you. We have a question from a participant, and I'll read this to you, Assaf. How do we know what is the right data size? And do we look at patients or embryos in the studies?
Okay, so those two questions. Sample size is in the case of AI is much harder to calculate. It's not like in other statistical clinical study that we do. But again, usually AI use big data, and in medical field, those numbers we will never get there. We're talking usually in AI, it will be thousands or millions of data. And in medical field, most of the time we will not get to those numbers, but it's reasonable, or it's obvious that probably just dozens of cases will not give us a really the answer if the AI works or not. So probably we are talking about hundreds or thousands of cases, probably will be the right number. But again, it's also it's very individual, because we need to look what is exactly the question, and what are the inclusion criteria. Because those two questions will answer out what will be the size of the sample size that we need to use to get more generalized tool with the AI.
Excellent. I have a couple of other questions that I think the audience might be interested in. For many of us on this call here, we participated in the AI conference in Dubrovnik, and one of the speakers there was from the investment field, Dr. David Sable. One of the expressions he used about where we are right now is, quote, "We're in the early innings." I think by that he implied that we still have some development to do. So my question is, at what point do you think the literature is stable enough and deep enough for a would-be practice to adapt a system for embryo analysis of the many that are out there? Early innings, the concept being there's still some development to be had, maybe new tools up ahead. So at what point do you think the literature would support a clinic pulling the trigger and saying, okay, we're going to do this. We're going to commit to AI?
So I think it's the same process that we had with more sophisticated statistical analysis that we did before. Let's take a look on 20 or 30 years ago. We started to have more sophisticated statistics, and at the beginning, we accept those tools, and then we realized that we don't really understand some of those tools, and we ask that statistician people, we get into the journals and take a first brief review of the study that they use those techniques. And I think this will be the first step of the journals, that to get AI people into the journals, to have a first review of the studies, to find out that the AI that the researchers use is the right one to get the right answer. Second thing that the medical or the biological people will really help those people to accept AI is if we will have explainable AI, which means that beside to just give the answer, how was the prediction, if it was fine or not fine, we'll also get the answer what exactly the machine was looked on, or what parameters it gets into its equation to get the answer. And when this will be reasonable, I mean, if we'll get the answer, what exactly the biological feature that the computer looked on, and because of that, he decided the prediction, this is something that will really help us to accept the AI tool and to use it in the future.
Excellent. For a moment, I just want to go back to the slide that you cited, the paper from HR in 2018. And the question from one of the audience participants is, how can we trust peer review? Also, during this conference in Dubrovnik, one of the points that were made is that I think one of the speakers actually polled the audience saying, how many of you have been asked to review a paper? And I think 20% of the audience raised their hand. The participant's question here goes to the point that this paper that you cited in 2018 from a very reputable journal, peer-reviewed, seemed to hold water when you first read it, but your dissection of it showed several pitfalls. So as a reader, the user of this literature, trying to make a decision about what to do, how do we look beyond just the peer review process? What sort of a gut check should we look for when we read these articles?
So I totally agree with you that the number of reviewers should be increased, and those reviewers should be familiar with AI and with the biological and biology, medicine, etc. And then maybe we'll raise more questions. I think this paper, when you look on this paper, you can find several things that we should pay attention to. First of all, you have to see what are the inclusion criteria. What exactly the data, what cases the data included. this is one question that you need to answer, because again, AI will give you an answer for the specific data that you are giving it. If you give another data, you may get another answer. So it's very, very important to see what kind of data we put into the machine. And this was the pitfalls of this paper, because if you get data that is not exactly what we are asking for, or what we are asking during our day work, you may get another answer that is not really relevant what you are looking for.
Yep.
Second thing is to look on the results. When you get the results, you have to see that you have enough data or enough results to answer the question, just the accuracy of the tool. Also, if it's prone to one side or the other, is it prone more to have positive results, or is it prone to have more negative results, or false negative results, or false positive results? Because again, in our case, the main question with embryo selection is to know to have a really high positive predictive value. And the main problem with most of the tools that they are more prone to give you a negative predictive value. They mainly will tell you what embryo not to transfer and not what embryo to transfer. And this is one of the pitfalls, because again, you may have less embryos that you want to transfer, but you don't know exactly which one of them to transfer. And to know if the AI is really giving you the right answer, we will have to, as I mentioned in the talk before, you should have the confusion metrics. So you will have to know what are the positive results and what are the negative results, and by that you will be able to calculate what is the positive predictive value, what is the negative predictive value, and then you will be able to know if this AI tool is really fine for you for the exact question that you raised.
Excellent. So, and I do envision in the future for peer-reviewed articles that there will be this kind of triumvirate of a biostatistician, a clinician like yourself or myself, Assaf, embryologist, and then an engineer that's sensitive and in touch with a lot of the tools and decision-making we face. So we can end with this. Assaf, that was excellent. Really appreciate your time and input to the Academy. And we'll look forward to the next session. Good afternoon, good evening to all the participants, depending on your time zone. So thank you.
Thank you.
Right.
Bye-bye.
Bye.